Hello everyone. Now I will discuss question of neurology. So we have a 70-year-old lady and she has been brought to you with complaint of progressively worsening speech. She was fairly well 3 years ago, and when the doctor who had only intermittently visits her, and she noticed that she had initially memory difficulties, and later on she became lost while driving to church 12 months ago, and she was nearly 50 miles away from before the police found her. She had been forgetting the name of her children also, and she has developed problem of gait and balance also, lost interest in everything, urinary incontinence for last 2 years, 2 to 3 years. Now impairment of balance and gait is there. She is unable to draw a clock and label the numbers. And what's the most likely diagnosis of this case? Well, the answer to this question is Alzheimer's dementia. Why? First of all, this patient has all the features consistent with Alzheimer's disease. In fact, Alzheimer's disease is the most common cause of irreversible dementia. And it usually occurs above the age of 60 years, and our patient is of 70 years. And this increases exponentially with advancing age. So definitely at least age fits into our criteria. Now, early finding include in these patients like visuospatial deficit. What do you mean by getting lost in own neighborhood? She became lost while driving to church 12 months ago and was nearly 50 miles away from her home, and the police found. Number two, problem with memory, like patient had memory difficulty, needed things to be repeated and had to remind about daily activities. Even she is forgetting the name of her children also. Memory problem is there. Very much cognitive impairment, language difficulty, progressively worsening speech is there. Memory loss typically precedes visuospatial deficit, the classical line that you can never forget this line. In our case also, patient initially had memory difficulty and the problem of visuospatial, that is she lost her way to home or the way to church. That is again late feature, but initially she had a memory problem. Late finding personality and behavior changes, like our patient has apathy, she has lost interest in doing anything. Neuropsychiatric hallucination, not in this patient at least. Non-cognitive like myoclonus and seizure, not in our patient. Urinary incontinence for last 2 to 3 years, it is there in this patient also. Apraxia, unable to draw a clock and label number. Well, we talk about apraxia, but what exactly is apraxia? Stop the video, write down the answer. Well, apraxia means the patient forget to do the learned motor activity. So, whatever motor activity which patient already knows and he or she forget, that is apraxia. So, forgetting learned motor activity is apraxia. In this case also, the lady cannot draw this thing, cannot number like this. It is a work that can be done by a small child also, but she forgets. How we diagnose this? Of course, mini mental scale examination, neuropsychological testing. We have certain criteria. 2 or more area of cognitive deficit, progressive worsening memory and other cognitive functions, no disturbance of consciousness, patient remain fully conscious. There's one point which is really very important in making diagnosis: no altered sensorium. Age onset after 60 years, our patient is 70 years. absence of other systemic or neurological deficit causing progressive cognitive defects. Well, before I proceed further, I have a question for you. What do you mean by cognitive function? We have been talking about cognitive function. Stop the video, write down the answer. What is cognitive function? Well, cognitive function, we use a broad term that is referred to mental process involved in acquisition of knowledge, manipulation of information and reasoning. That means that is what we are gaining day by day. Okay, this cognitive function. So this includes perception, memory, learning, attention, decision making, and language abilities. They're all the part of cognitive function. You can see everything this need to be learned on day-to-day basis. That means in such cases they forget to learn more and more skills, as I mentioned, maybe memory, maybe attention. They are not able to decide also. Well, our patient have a rapid course late onset Alzheimer's disease. 3 years according to her daughter, with raised concern about other dementia. Okay. Many patients frequently have missed symptoms for years together during the early phase. Said the daughter is visiting occasionally to the mother. Maybe she missed the early stage and she noticed the problem only for last 3 years. That's why we can, and moreover, by the time patient has come, already cognitive function are impaired, and she's having apraxia also, learned motor activity. That means the daughter has seen the mother in the advanced stage of Alzheimer's disease. Now, urinary incontinence is again a late feature, but this can occur. Otherwise also in elderly lady, this can happen. But that's really, again, if it's there in this patient, this could be Alzheimer's disease also. Now, I have one more question. In this patient, we also investigated for thyroid function, stimulating hormone, and vitamin B12. What is the importance of doing these tests in our patients? Stop the video, write down the answer. Well, the answer is hypothyroid and vitamin B12 deficiency. These can lead to dementia. And every case of dementia, these two should always be investigated. The reason being, they are the two reversible cause of dementia. Okay, so it's a treatable cause in contrast to Alzheimer's disease, which is almost irreversible. But if you treat, patient become near normal. That's why for every case of dementia, these things should be ruled out. Other thing that should be ruled out in case of any dementia is CT scan of the head, because subdural hematoma can come like as a dementia. And of course HIV, and of course neurosyphilis, which is not a disease nowadays. CT scan and HIV should be ruled out. Okay. Now let's look into other options. Subdural hematoma, which I mentioned in the previous slide. This chronic subdural hematoma can come with same problem of dementia. This is especially in elderly and alcoholic patients. Okay. In this, they usually have a headache, long history of headache. Maybe they may be having some cognitive function and memory deficit, decreased consciousness, aphasia, and motor deficit. They can also occur, but this is a commonest problem. Now, I have certain question for you. Why it is common in an alcoholic patient? It is due to bleeding of which vessel, and what shape of bleeding is seen in CT scan? 3 questions for you. Stop the video, write down the answer in your copy. First of all, the bleeding occurs due to rupture of the bridging veins. Look, this is the superior sagittal sinus, and they are the veins from the brain, and these are bridging veins, which lies between the superior sagittal sinus and the subarachnoid space. They get rupture and they lead to subdural hematoma. Okay, you can see the picture here, much better picture. You can see This is the bridging vein, and this is going to superior sagittal sinus, and they get ruptured. Which whether it is the bridging vein get ruptured. Second question was, is why it's common in alcoholic patient? This rupture can, even a trivial trauma, can cause rupture of these veins. Now, in alcoholic patient, there is no point in taking history of trauma. He must have had drunk sometime, very heavy drinking. He may have fallen. So that doesn't carry much meaning. That's why it's very common in alcoholic patient. And what picture we see in it is, you get a picture like biconcave. You give biconcave. This is in contrast to this is in contrast to a patient who has got epidural hepatoma. They have a biconvex type of shape is there. Okay, they have biconcave. Now, dementia with Lewy body is the one more option, usually associated with Parkinson's symptoms. The clinical features are gradually progressive dementia, fluctuation in cognitive function. Very, very important point. In contrast to Alzheimer's disease, where it goes down drastically. Persistent with well-formed visual hallucination. If this is the one point which strongly give a favor that we are dealing with dementia with Lewy body, what we write as DLB. Catch point for DLB. Extrapyramidal symptom, again favoring toward Parkinson. The two things, golden line to remember is visual hallucination and Parkinson-like feature. Visuospatial dysfunction can occur early, and memory deficit occur late in the course. It's a reverse of what we get in Alzheimer's disease. What is, again, I have stopped the video, write down the answer. What is Lewy body? Okay, write down the answer in a copy. Well, it is created by decay of tissues in the brain. So it is something degenerative material or decaying material in the brain is Lewy body. Okay, they have an abnormal protein particle in the brain. Lewy body are seen in people with Parkinson's disease. Now, other option is normal pressure hydrocephalus is characterized by abnormal gait, dementia and urinary incontinence. Classical triad. In our patient, there is a gait abnormality there, urinary incontinence, and dementia is also there. But gait impairment is the most important and early feature. In our patient, it was late feature. Memory deficit is a late feature here. Gait abnormality is an early feature, but in our patient, memory deficit was the first feature. That's why it goes in favor of Alzheimer's disease. Gait is a broad and shuffling gait. Stop the video, write down the answer. What is the name given to this type of gait? Stop the video, write down the answer. Well, we call this magnetic gait. When the patient walks, he will not lift his feet from the ground. He will just rub on the ground, what we call as magnetic gait. Well, subcortical and frontal feature dominate the cognitive disturbance of NPH and occur much later in the disease. Cognitive dysfunction are the late feature. In contrast, in Alzheimer's, they occur a bit early. Well, the patient cortical speed difficulty are less common in NPH and favor Alzheimer's disease. Cortical function dysfunction is the late feature of NPH. Look into CT scan. You can see this is the normal pressure widen. In CT scan, you can see there's a huge enlargement of ventricle. In contrast, in Alzheimer's disease, there's a cortical atrophy is there. Cortical atrophy is there. Cerebral atrophy, or better we use the cerebral atrophy is there. Here we are getting enlarged ventricles. Finally, multi-infarct dementia, option E. This is vascular dementia, typically present abruptly. In contrast, Alzheimer which progress start insidiously. Stepwise deterioration. If you are getting this word, this is the like this thing. So patient will stable for some time, suddenly deteriorate, stable for some time, suddenly deteriorate. Stepwise. So now you are getting keyword to remember. Gait abnormality in NPH. Headache in subdural hematoma. Sudden onset with stepwise deterioration is multi-infarct dementia. And patients usually have feature of risk factor of CED like diabetes, hypertension, smoking, hyperlipidemia. They are the additional features that we can have in this patient. Okay. Well, now deficit in executive dysfunction are much more severe than those in memory early in the course of disease. Vascular dementia is less likely in this patient due to more gradual symptom onset and absence of previous stroke. Now I have one more question for you. Stop the video, write down the answer. What is Binswanger disease? Write down the answer. Binswanger disease, also known as subcortical leukoencephalopathy and subcortical arteriosclerotic encephalopathy, what we write as C, is a form of small vessel vascular dementia caused by damage to white matter in the brain. White matter atrophy can be caused by many circumstances, including chronic hypertension as well as old age. Well, you can see all these are the multi-infarct in the white matter. Golden line to remember: Alzheimer's disease is the most common cause of irreversible dementia above the age of 60 years. Early memory loss is the early feature. Visuospatial impairment is a late feature. Gait abnormality is the most prominent early clinical feature of NPH, but later finding in Alzheimer's disease. Thank you very much.